I think the session is highlighting the point that we have an expression in the southeastern U.S. of preaching to the choir, and I am preaching to the choir here. We're all believers, but time and time again, what we're seeing is that these data need to be disseminated out to our colleagues, because the biggest hindrance to us taking care of patients with advanced disease is not the ability of us to do that, it's the ability to us to get access to these patients, and instead of them being listed as futile by the primary cares and their pulmonologist and never sent for even a consultation. One of my mentors, Griff Pearson, said the best way to improve the survival for lung cancer is more operating room time. I say that in jest, but it's actually true that the only way we're going to make an impact is actually be able to have multidisciplinary teams with central referral and centers of excellence. Moving right along, small cell lung cancer is usually not considered a surgical disease. And I have to, for full disclosure, on my other side of the family, I'm a Harpole. This is Harpole in Northamptonshire. Actually, Princess Diana is buried 1 mile from the church there, and its population of 1350. Unfortunately, I found out my name actually means dirty pond in Old English. It's not particularly, but they have this lovely scarecrow festival. The next one is September 7th through the 10th, which is pretty well known in the UK, and it's actually a very lovely area of golf courses and things. Google's right down the street, and what's nice is that the town, which had not seen great days 30 years ago, has been completely restored by all of the techies who now have thatched roof homes in Harpole. So anyway, that's where my other side of my family's from. So advances and challenges in limited stage small cell, and I think that's what we're going to talk about. I'm going to go through a background, some of the landmark North American studies, some institutional retrospective studies, some national population-based studies, and then look at long-term survival. Now, the best thing to say, first of all, there's no level 1 evidence here. There's no randomized trials because these are relatively unusual, but I think there are enough data here that we can at least glean some important assumptions. So first of all, although we stage, since the 8th edition now, we stage small cell lung cancer as the same as small cell with TNM, still from a practical standpoint from medical oncology, it's limited or extensive, and it's very simple. Limited is confined to the ipsilateral chest and mediastinum versus distant disease. And so we're going to concentrate on the more limited stage, which is the stage 1 to N2-3A. So the very first thing is there are randomized data here. The Lung Cancer Study Group in 1994 published in Chest the results of a randomized trial. These were patients, now this is again the very early CT era, patients were diagnosed with central tumors by bronchoscopy. You see the inclusion dates were 83 to 89. They had to be limited and potentially resectable. And they excluded those with peripheral small cells, which I'll talk about later because they're really a different group. And those with normal bronchoscopy. So these are particularly extensive local tumors. The treatment regimen was induction chemotherapy. It was platinum-based, mostly etoposide. And then they had to have an attempted resection, followed up by thoracic and brain irradiation. Again, this was of the 1980s. It was not conformal therapy that one would use now, so a little less in quality. And then if they didn't have surgery, they were given induction chemotherapy followed by the radiation. So they actually randomized 146 patients, roughly half and half, to either the surgery or the non-surgery arm. They had an 83% resection rate in the surgery arm, which to me seems quite high. I think these were probably a little more limited than the chest X-ray or CT with massive N2, N3 disease. And the median survival was 15 months. And these were functional class 0-1 patients, so you could probably guess that their survival was more due to their lack of disease progression during that interval. No surgery was even better, and there was no difference in the curves. The 2-year survival was 20%. I've been considered by my colleagues a psychotically optimistic person, but even I can't see a difference there. So it's difficult to say anything. So in summary, that prognosis for limited stage small cell was poor. This randomized trial did not show benefit for surgery for limited disease, and quote, Dr. Thomas Shields from Rush in Chicago said surgical intervention for this disease fell into disrepute. I liked his statement there. And that's kind of where we set for a while. Wilfred Eberhardt, as you know, is a leading medical oncologist in Germany, and they looked at their disease small cell patients that were more localized and had frankly been trying to figure out what to do. So they came with a protocol where they had mediastinoscopy, and then the patients were staged by that, and they selected those for a multimodality approach. And what they found was, if you look at on the two panels here, there's the event-free survival for the completely and incompletely resected patients, and then the survival from a different, these are two different sets of patients. But you can see that in the patients that were completely resected, there wasn't a reasonable survival here. And so they introduced the possibility that surgical treatment could be an option for limited stage patients. And I think that sort of set the ball rolling for us to rethink our situation. Simultaneously, there were a couple of small single institution data sets. Malcolm Brock from Johns Hopkins looked at their data set. Hopkins has a very extensive small cell group there with obviously the vast majority of the patients being treated medically, but they did have a smattering of 82 patients that they looked at and saw reasonable numbers of patients who did have outcomes of surgery. And when you looked at the overall survival for these patients who underwent surgery for stage 1 disease, you could see the stage 4 group sort of head straight south, but the stage 1 and 3A and 2 patients did. And then you can see those who had platinum versus non-platinum. Again, that's more of a decade versus time because obviously we've been using platinum-based therapy more commonly. So that led us and others to look at larger data sets. Gilbert Schreiber is a pulmonologist interested in lung cancer who, as the University of Arizona was at Duke previously, and he looked at the SEER database. And for those that are not familiar, the SEER database was set up in the 80s as a way to collect information on large numbers of cancer patients. It's about 20% of patients in the U.S. The strength of it is there's high penetrance in that area with lots of data. The shortcomings of it, it's very regionally based, so it has Hawaii and Iowa and things like that, so it's not a national thing, but it is all those patients in those areas. And so they looked at their limited small cell patients, which was over 14,000 patients during that 14-year interval, and they divided them based on local or regional, and they tried to make them as nodal negative as possible. So if they had advanced nodal disease, they were not included. So these are the ones that were either clinical N0 or questionably clinical N0, the NX. They had a 28-month median survival for surgery versus 13 months for no surgery, and obviously that's not randomized, and there's all kinds of shortcomings from this. There's potential treatment bias and so forth, but here are the data for the patients who were N0, and it's very provocative. And if you look at the N1 and N2 patients, the green lines are those who underwent surgery. So again, it seems to suggest that, is there something here? And there possibly could be. And when they looked at patients who had postoperative RT with surgery, those that didn't, the postoperative RT seemed to suggest that surgery plus some sort of adjunct also may be beneficial, with all of the caveats taken in. There was a follow-up paper in 2012 by Dr. Weksler from the University of Tennessee where they looked at a more recent cohort, again, of SEER data, and they concentrated on the stage 1 and 2 patients, so that these were not N2 positive, these were N0 or N1. And then they looked at the type of procedure that they had. Now you notice the numbers have dropped dramatically because they have concentrated on surgical patients. And then they compared those who had surgery with or without radiotherapy. And again, those who underwent lung resection are shown in red. And then you can see that it appears in this small set that in red are those in the right-hand panel here that tend to do better if they have an anatomic resection versus those who had a non-anatomic wedge. When they looked at the stage-based data, for those that were stage 1 in the left panel, those at stage 2, again, there seemed to be an advantage for those who underwent resection versus those that did not. So what we wanted to do then is to get some more information of the best data we could collect. And so a few years ago, we started mining the National Cancer Database. And the National Cancer Database is a little different. It includes, it's 85% of all cancer diagnoses in the US, but there's 72 to 4% of all lung cancers. The advantage of this database is that every hospital that has a tumor registry that's approved by the American Cancer Society has to include data. The data is all included or abstracted by teams of data registrars who are independent from the treatment teams, but are master's level trained people to extract the data. And so what we did is then we gleaned from that information patients who had complete resection with concurrent radiotherapy. And so we have a series of things we wanted to show you here. This is probably the best data out there, albeit not randomized. So if you look in the best of the best, and these are more the stage 1s who are the peripheral small cells that one takes out thinking they may be non-small cells. So these are the clinical T1, T2, N0, M0 patients stratified by surgery versus those who underwent chemoradiosurgery. And you can see here, this is an unbalanced set. There were 700-ish patients who had surgery and about 1,600 plus who had chemoradiation. So on the view there, it looks like the blue line is significantly better. But what we did is then we propensity matched them for 15 factors because this database is very inclusive to try to give a better idea. So these were matched for 15 variables. There's 536. Let me go back. Yes, I'm sorry. I'm seeing the number over there. I apologize. 536 patients in each arm, and one can see even when one matches them the best we possibly can from these data, there seems to be a significant advantage for surgery. So in a multivariate model, in these patients, when they see down at the bottom, they were adjusted for age, sex, race, year of diagnosis, median income, urban versus non-urban facility, hospital volume, distance from the facility, their disease score, and their clinical stage. So these were all the variables, interesting enough, that we found that were dependent predictors. That there is a pretty good hazard ratio, and a hazard ratio of 0.58 is a pretty good advantage for those undergoing surgery. So due to that, the NCCN rewrote their guidelines based on these data and now recommend surgery for those patients. So what about other patients? Well, we looked at N1 patients. Again, same data set, but those at N1. Now you see the number of procedures here is quite reduced. The number of patients in the surgery arm was 96 versus 945 that had concurrent RT as the bias of treatment. But there was significance there. And when we propensity match them, now, I'm going to throw my hands up here. This is 87 patients in each arm, but again, they're matched those variables. It actually looks like a pretty strong association between surgery and adjuvant therapy versus concurrent chemoradiotherapy. And as we said, again, the adjustment was for the same set of variables, although not as significant, but 0.74 argues a pretty good hazard ratio in favor of surgery. And this is surgery with adjuvant chemotherapy, and I'll talk more about that. So what about N2 disease? Well, this is where we're getting a little bit more into gray area, but for patients who were proven N2, stratified by surgery, 101 patients. Now the concurrent chemorads arm is 4,600 patients, so again, quite a large difference here. Slight advantage. But when we propensity matched them, there were 94 in each arm, and there seems still to be a reasonable trend. And again, just about the same as for N1 disease, the hazard ratio was 0.73. So what we wanted to look at is then, all right, if the surgery's better, if we could define what happened to the patients afterwards. So this is looking at those who had adjuvant chemotherapy versus those that didn't. Again, this is the very peripheral disease. These are the patients who were found to have small peripheral small cells. Then they're given etoposide platinum, and at discretion of the oncologist, given prophylactic cranial radiation. And you can see that there was an advantage for those who got the adjuvant therapy shown in red. So in summary, I think the takeaway message that patients with T1 and 2 small cell can benefit from both adjuvant chemotherapy, chemotherapy with PCI, and that's what's recommended, and that's now the recommendation from the NCCN for adjuvant chemotherapy if one operates on small cell, is to give 4 cycles of etoposide platinum afterwards. They also recommend PCI. Now the data for this are obviously very soft, but if you take the correlate of this being like limited stage small cell, we know there's an advantage for that. So, is resection for N0 and N1 small cell can safely be performed? I put in question mark. I think that's a reasonable thing for us to do. Surgery for N2 disease, you know, I put a question mark. I think there are probably selected patients that may be worthwhile, and we're very selective with you know, invasive staging and so forth ahead of time. There's certainly a great role here for neoadjuvant paradigms, which are obviously not going to have to be multi-institutional. They have to be multi-continental to really do this, and I think it's a real opportunity for us to look at these things, you know, across the pond and in Asia. That chemotherapy and PCI should be given following surgery for limited stage, and again, the data are not level 1 evidence, but they're reasonably strong. And it's evolving, and so I think that, and my final point is that if we're going to learn anything, we need to aggregate our data and start looking at these things, because I do believe there is a role for surgeons in small cell, and in fact, we have some other data that shows, interestingly enough, I'd almost rather have limited stage small cell now in my institution than 3B non-small cell, because our survival is much better for limited stage small cell in Durham. So, you know, I thought if you asked me that 20 years ago, would I say that? I would say you're crazy, but we've definitely advanced. Thank you.